one of the things that I think becomes important is part of the reason that CPAP is not the singular solution, but is a part of the solution, is because of the fact that we have different reasons as to why people develop obstructive sleep apnea. Over the lifespan, we do see different contributory factors. For myself, where I'm looking at children who have obstructive sleep apnea, we very frequently will talk about the child who is prepubescent, that is probably tonsils and adenoids. Post-pubescent, you start to see more of the approximation of similar things to the adults. However, I'm a neurologist. There's many times where it's not the tonsils and adenoids, it's not the weight, it is the neural tone, because the same signaling that is contributing to inappropriate muscle tone in the periphery or inappropriate signaling contributing to epilepsy is the same inappropriate signaling that's contributing to the upper airway. So when thinking about the endotypes of obstructive sleep apnea, first and foremost, I would say in many patients, it's not the singular. It's not one endotype that is contributing. How would you guys approach framing out endotypes or the contributing mechanisms of the development of obstructive sleep apnea? Because I think that this provides the foundation of when should I be thinking about obstructive sleep apnea? Because if you're missing a pure Ruben every time, then you are not going to identify the person with a slight microretroagnanthia that is still not being able to breathe during their sleep because they also have a nasal septum issue.
Yeah, I can respond to that. Want to hear the comments of my colleagues here as well. But to your point, Anne Marie, Rakesh Bhattacharjee is a mutual friend of ours who had a paper with David Gozell in the American Journal of Respiratory Critical Care Medicine looking at adenotonsillectomy in children. There's a fair amount of residual disease there. If the whole problem is tonsils, that should solve the problem. And similarly, on the adult side, the tirzepatide data that we had, people lost a ton of weight and their sleep apnea improved, but there's still residual AHI in many cases, suggesting either they didn't lose enough weight or there's other mechanisms, as you're suggesting, control of breathing, upper airway muscle function, or craniofacial structure that's not just adiposity related. So there are lots of different factors there. And to your point, I think it's complex. It's not one factor.
Yeah. And I love the fact that you brought up David Gazelle because I always say to him, I'm like, he's like he's like another sleep celebrity that I'm always like, I have to work with you. I have to spend time with you. I just want to learn from you. Really another person who's done a tremendous amount for the field, especially in pediatric obstructive sleep apnea. And recently has been contributing also to some machine learning understandings to be able to better contribute to the recognition as well as the prognostication. Reena, what are your thoughts about this?
Yeah, I think this is emerging as really a fantastic framework for us to work with in terms of understanding what's contributing to the sleep apnea in terms of, the collapsibility of the airway, what we call loop gain, which is kind of the stability of of breathing, arousal threshold, muscle responsiveness. So these kind of key areas that, and as you said, it may not, it's like most of the time not isolated. There's overlap between these underlying contributing factors. And as we think about this, and of course, then that allows us to then consider, personalized sorts of approaches in terms of treatments, being able to target those specific areas. And historically, it's been difficult to accurately glean these endotypes because it really requires doing in-depth testing in the proper environments. And now emerging is our ability to glean this from these endotypes from sleep studies. And so that hopefully will make that more accessible to providers to be able to really apply it to clinical care. And so, yeah, I really appreciate the work that Atul has done in this area. And I have to say, really appreciate Azizi's comments as well about, the community-based approach and then, utilizing that approach, this approach in that setting as well.
Yeah, and I also think that there's this ability in the community to further the idea of, do we have all of the endotypes, and how can we think about that? I think the other piece when I think about the full lifespan is the endotype that may have caused the initial obstructive sleep apnea, if left untreated, is not going to be the only endotype that's contributing. If it was because you had tonsils and adenoids that was causing you to potentially have that, and recognizing even in that population, I don't think that's ever the singular cause, because why could I have two kids who both have kissing tonsils and one has OSA and the other doesn't? That is already telling you there's probably something neurologic difference there. But you leave it untreated, you only are going to have more things that break downstream, right? And so I do think that that becomes important. I would say for the providers who are listening to this, why should you care about endotypes? If you're going, you know what, I don't care, I'm going to prescribe the CPAP anyway. Well, because when they're not a CPAP responder, you need to be able to think about this. But secondarily, I'm always one to talk about, how do we battle the insurers? The insurers need to understand we're trying to make it work for you. We're trying to get the solution in the hands of the patient that need the specific solution. Don't make me battle with this one way where I know that that's not going to be the right answer. So, Azizi, what are your thoughts on this?
No, I think this is, as Reena has mentioned, that this is certainly an emerging, area of our field that in many ways provides tremendous promise to how we treat individuals, particularly as we try to better understand the etiology of disease and how those etiologies are linked with the course of treatment. And I think that is important. But again, Anne Marie, you said we're friends here, so we can't be friends without actually adding some color to the conversation. So while I believe that endotypes certainly provide tremendous promise, they are in many ways, and not to get too philosophical, they are phenomenological descriptions of symptomatology, although they are linked to some potentially underlying causal model as to what is the genesis of this particular disease trajectory. Nonetheless, there still needs to be more research linking the endotype with the particular treatment and the course of
Absolutely.
treatment.
Absolutely.
And I think that is where I think I am really excited for the work of my colleagues here and others to be able to provide a body of evidence to be able to find what treatment works for whom, at what dosage,
Yeah,
at what within what context. Because as you mentioned, Anne Marie, that this can help to determine, when something or if something is actually insured or not. And I think that that is where, I see tremendous value. But one of the things that I think endotypes also provide is how is it that the treatments that we have, particularly the medical, whether it be device-based, whether it be surgery, or whether it be some type of oral appliance, how do those actually interlock with behavioral sleep
absolutely.
hygiene as well? And I think that is where we still need to do more
Yes.
because the level of adherence based on your endotype profile can really be a critical component, right? So, if you have an endotype where your sleep apnea is caused primarily by structural, reasons, it is very likely that even when you were to reduce your body weight, that it can significantly mean it may not actually lead to better results. And those, the lack of results per se
Yeah,
may actually significantly impact someone's compliance long term. And I think
absolutely.
that's kind of where I want our clinician community and researchers to cue in on that the endotypes do, although they provide a window in understanding etiology that can lead to course treatment, that we must start to look at how this significantly impacts the behavioral complementary practices and treatments that we provide as well as adjunctive types of solutions.
Absolutely. Atul, did you have something you want to add on?
Yeah, I did, and well stated, Azizi. Thank you. So I just want to make a semantic distinction between endotypes, which are mechanisms underlying disease, and phenotypes, which are clinical expression of disease. And we have some data linking the two, saying that the mechanism underlying sleep apnea might affect clinical expression. And so some clinicians ask me, why should I care about this? This is just research, and how best to measure it, we don't even know, et cetera. But I think there are reasons that these things matter. So one would be, which is the best therapy? So often CPAP is quite good, but there's lots of patients getting uvulopelvic pharyngoplasty, and there is a subset of patients who have anatomical compromise at the level of the velopharynx who probably do quite well with that kind of surgery. There's others who do very poorly. And if we can identify the home runs or the strikeouts ahead of time, then we can stack the deck in our favor and do quite well. Similarly, different people get sleep apnea for different reasons. So among neuromuscular patients, Anne-Marie, that you were talking about earlier, knowing why they have sleep apnea can be quite helpful. So we can target the underlying cause and improve treatment that way. As I mentioned, the endotypes can predict phenotypes. So we have some data that the high loop gain, the unstable ventilatory control patients have sort of jacked up sympathetic activity, or they're the ones that get the biggest bang for the buck with CPAP in terms of blood pressure improvement. So again, we can stack the deck by understanding mechanism and how that affects clinical expression. Similarly, speaking of the lifespan, elderly patients may have less or fewer consequences from their sleep apnea compared to younger individuals, and that may also relate to underlying endotypes of disease, that the mechanism of disease is quite different. The high loop gain patients are much more common in the younger cohorts than in the older ones.
Yeah.
Then the final point is predicting response to therapy. So, for example, you put some people on CPAP and they develop insomnia. That could be related to a low arousal threshold where they're prone to wake up, and the treatment emergent insomnia can be problematic. Others with unstable ventilatory control may get treatment emergent central apneas. And again, if you're not thinking about these things, then you'll have some treatment failures that result. And so I think there are lots of reasons why it matters. Some of this is research, but some of it is important clinically. And I think if you're not thinking about these things at all in your patients, then this one size fits all approach has largely failed.
Yeah. Reena, go ahead.
Just, briefly, I think this is, so well said, Atul and Azizi. I also think that, we have the endotypes, and then we also have the consequences, the physiologic consequences of sleep apnea as well. And historically, using for sleep apnea, the apnea hypopnea index, and now recognizing that there's value to that. However, there's also value to understanding the specific aspects of the physiologic consequences in terms of the hypoxia with sleep apnea, hypoxic burden, the heart rate arousal response, getting more at these kind of specific physiologic ramifications, which in of itself may help inform, the path forward for an individual clinically in terms of different diagnostic subtypes, and then also in terms of how you would approach treatment, and how it's related to adverse clinical outcomes.
Yeah. So as you can see, there's a ton from an endotypic conversation. Azizi, I'm going to let you speak in a moment. One of the things that I think also is important to think about is there's the endotypes, right? Where I see someone where it's either the craniofacial features, it's the obesity, it is these other factors that may be innate to what the person, just the way they're composed. However, there also is the secondary piece of the person who has a high risk morbidity. So maybe it is obesity and you're going to be undergoing bariatric surgery. Maybe it is atrial fibrillation and they're going to be undergoing an ablation. One of the other features that I think is underappreciated is we're seeing that there's an increase in screening. However, we're recognizing that there's still a mismatch in what I'm screening with a piece of paper or an inventory, and whether I just do, this is a patient population where X percent, 85% are going to have. Should we be just skipping the screening and just saying, we don't want to miss anyone? Should we be doing home sleep testing as the screener in those types of populations, recognizing that that is a higher risk population? Now, this is going to be switching from endotypes. So I know that I want Azizi to finish his comment about endotypes, but then we're going to jump into how are we creating these kind of pathways to think about how we're able to solve for this. And the reason this is important to me is because I've been asked these questions by my CEO, I've been asked by our innovations team, by different clinical leaders, and they all just want the simple the stop bang or the Berlin questionnaire. And every time I cringe because although they're validated screening tools, I worry about the inability to appropriately capture an individual and actually set someone off on the wrong pathway that they're going to get lesser care. So Azizi, go ahead, and then we're going to flip over.
Yeah, no, no, sure. And if you'd allow me, I might try and serve as a bridge.
Sure.
Because one of the things that and it's a quasi question to my clinical colleagues. We talk a lot about endotypes, but primarily endotypes are derived from PSG. My worry and fear is that in the desire to increase screening and assessment at the population and community level, there's going to be, I believe, a greater uptake of, home sleep apnea testing. And if home sleep apnea testing are unable to be
Mhm.
able to determine endotypes, then you have that mismatch as well. So for example,
Great
ideally
point.
from a care pathway standpoint, if we want to really fully characterize individuals from the moment they have a complaint or from the moment of screening and assessment, I believe that's where we need to make our data a lot more rich. It needs to be richer from that moment. And this is some of the things that we have committed to and we're currently working on in
Sure.
terms of finding ways in which we can be able to capture risk through craniofacial morphology, which it may not capture the entire 100% of individuals who have sleep apnea, but it can allow us to start building that corpus of data that would allow us to use higher level AI and
Yeah.
other forms of technologies to start figuring out a taxonomy, right? So I'm in the space of psychiatry, clinically. And so we have the DSM, and the DSM really centered around phenomenological taxonomy. I'm not saying we should do that, but at least that type of taxonomical framework is needed to be able to be brought in where you're capturing people ahead of time so that when the care pathway is laid out, then you can then determine what pathway works best for whom, and then empower the treatment team to determine what kind of levers you need to pull in
Mhm.
order to get that person the necessary treatment in a more efficient way. So I'll pause there because I know I took up a little bit more time because I was trying to serve as a bridge.
Yeah.
But I'm happy to chime in after maybe Atul or Reno
Yeah.
shared.
Yeah, I could add a little bit to that. We do have some data. We published a paper in the American Journal of Obstetric Critical Care Medicine a couple of years ago on getting a loop gain, the control of breathing parameter, off a home sleep test, looking at the response of the disturbance. Jeremy Orr from my group had that paper that's there. So I do think we can do this with reductionist sort of methods. I think to the point about using machine learning or deep learning approaches, many of these benefit from multimodal approaches. You get some data from the sleep test, you get some data from the demographics and these
Absolutely.
sort of things, you get some from blood biomarkers. If you bring in lots of different parameters, then you start to get, quite high sensitivity specificity using those approaches. And so I think there is opportunity there. People say, well, you're stuck with PSGs, you're never going to move forward. That's simply not true.
I would just add on to that one would hear that and go, yeah, that's space age. We'll see that in another 20, 30 years. But what I think what you're describing is something that is absolutely practical right now. When I hear Zizi talking about craniofacial features, we had published on this a few years ago, doing 3D image of craniofacial features and being able to predict the comparison of them having obstructive sleep apnea versus the polysomnography, and it was something like 75%. And I'm sure that that type of technology has continued to improve. But do we need 3D imaging versus people go to a dentist? There is panoramic views of your oral cavity, and that is including the bones of your face. And so, is it that if we cut down the silos between medical and dental, that we actually could identify individuals much better? So the same as you're saying, it's multimodal. I absolutely believe in that. I believe that there's not ever a singular biomarker. It definitely is multiple. But can you take singular pieces from your multimodal as the, hey, you may be risk stratified as higher risk. So no, I went for my normal cleaning. They did my x-rays and are going, you have a little bit higher arch than what is appropriate. And because you're perimenopausal, you may want to think about like, how are you sleeping? Are you waking up earlier than desired, feeling unrefreshed? You may have a REM specific sleep apnea, right? And so if we're able to get to that type of experience, then I really do think that we're going to see how you're able to actually implement something like this today. Go ahead, Reena.
Yeah, this is great conversation, and I think as I'm listening, I'm also thinking about this whole concept of the exposome in terms of environmental exposures that kind of lend itself in that kind of model of thinking as well. And then to your point, Anne-Marie, about the screening, I think that this is a challenge for our field. We have these kind of standard screening instruments. I also worry that are we missing in certain populations? How well are these kind of standard approaches really working in women, for instance, and those with cardiovascular disease? We know that these questionnaires and screening instruments and tools just don't perform as well. So, and we want to make sure that we're not missing sleep apnea, which we know can really kind of shape the trajectory and in terms of increasing risk in a lot of these vulnerable populations. So, I think we as a field need to do better in many areas, and this is one of them.